other parts. So there will be an obstruction of blood supply to some parts of the brain. This variety of stroke is seen in diseases where a clot forms on the left side of the heart and is carried up in the blood system to lodge in one of the cerebral vessels. So when there is an emboli, and that means that emboli is coming from somewhere, commonly in the left side of the heart, and it may block the arteries in the cerebral. Okay, so there will be no blood supply to that area. So the diseases which most frequent cause a clot in the left side of the heart are: one, we have mitral valve stenosis with atrial fibrillation. Then we have myocardial infarction and subacute bacterial endocarditis. So, hello? Hello? Are you able to hear?
Sir. Yes, I can hear you.
Okay, so I was saying the diseases which most frequently cause a clot in the left side of the heart. One, it's mitral valve stenosis with atrial fibrillation. Then we have myocardial infarction and also subacute bacterial endocarditis can cause this the clots in the left side of the heart. Okay, then let's look at risk factors. What do you think are the risk factors for this CVA? What do you think are the risk factors? When you look at risk factors, these are not causes, but they are predisposing factors, okay? So now when you look at these predisposing factors or risk factors, we are saying that one, it's age. CVA is common in people aged between 60 and 75, 60 to 75% of all strokes occurs in persons over 65 years of age. Okay, so when you look at the age, you realize that 60 to 75% of those that are affected are aged over 65 years of age. Then the second predisposing factor or risk factor, we are looking at sex. Which people or sex is mainly affected with this stroke? We are saying that men have slightly increased incidence of stroke than women. So meaning male are more prone to CVA than female. Then also we look at race, okay? When you talk of race, we are saying that it is believed that Negroes are more prone than any other race to this stroke, okay? Then we have people that have hypertension. We are saying hypertension is a major risk factor for stroke, particularly in combination with the atherosclerosis. That is the thickening of the arteries, okay? Then we also have people with heart diseases. One of the major contributors of the stroke, both from atherosclerosis and embolism. So those people who have atherosclerosis and embolism are more prone to CVA.
So monitor. You admit. Okay. People are waiting.
Okay, so we are saying that those with heart diseases, they are more prone to getting stroke. Okay. And also, when you look at the diseases, also those that have diabetic mellitus. So diabetic mellitus, we are saying associated with the microvascular and the macrovascular changes that contribute to atherosclerosis. We know to say that these people who have diabetic mellitus, they have a lot of complications, and these complications, they have changes in the vascular system, the blood system, okay? The vessel system, blood vessels, they tend to change. Hence, they will result into atherosclerosis. And also we have others. Others, we are saying that those that are smoking a lot, okay? Those that are smoking a lot of cigarettes, they are more prone to CVA. And all those that are on oral contraceptive, especially if also smokers, those that are on oral contraceptive and also they do smoke, then we are saying that these are more prone to getting cerebral vascular or having cerebral vascular accident. And also we are saying that alcohol intake, okay?
Now it is reaching 7.
Hello?
Hello, sir.
Yes, we are saying that those people on oral contraceptive and those they should be smoking are more prone to CVA. Then alcohol intake and a family history of diabetic, then those are prone to CVA. Okay. Any questions so far? We have questions before we look at pathophysiology. Questions? Okay, so let's look at the pathophysiology of CVA. Okay, we look at the pathophysiology. Hello. Let's look at the pathophysiology. When we look at the pathophysiology, we are saying that the brain must receive a steady supply of nutrients from the blood because it has no capacity to store either oxygen or glucose. When you look at the brain itself, the brain cannot store any oxygen, neither can it store glucose. So it is dependent on the blood to supply the brain with this oxygen and glucose. It is supplied with blood from two major pairs of vessels, and these are the carotid, internal carotid, and also the vertebral arteries. Okay? When you look at this,
I think we can, that's what I told you.
hello?
Record and send, they must be something in record and send. Yeah, the way we do it, we are able to lecture, and then it's not able to record. So at the end of it, there are those people who are in the outside.
Hello? Mutembo?
Then this man, I install Manza, I install. So if someone is taking class, it is not easy from the home. So we need
to find a place where
are you able to hear
setting
Mutembo? Hello?
In class.
Huh? Yeah, just bring.
Okay. So now,
oh, you need to.
So we are saying it is. Hello? Are you able to hear? So,
Yes, I can get you.
okay. So now we are saying the brain must receive a steady supply of nutrients from the blood because it has no capacity to store either oxygen or glucose. And it is supplied with this with blood from two major pairs of vessels. That's the internal carotid and the vertebral arteries. So the complex process of cerebral auto-regulation maintains blood flow to the brain at a fairly constant rate of about 750 mils per minute. Okay.
Sure.
I muted all of them, so you can. No need to ask them whether they are hearing or not. They are hearing.
Okay.
So they are not doing.
Okay, so I'm saying that the complex process of cerebral auto-regulation maintains blood flow to the brain at a constant rate of about 750 mils per minute. Okay. So now we are saying the cerebral vessels dilate and constrict in response. The cerebral vessels dilate and constrict in response to blood pressure and also in response to carbon dioxide. Okay, the carbon dioxide tension. Ischemia will cause primary death of cerebral cells or cerebral infarction, which creates a core of necrotic tissues. Okay? There is a secondary area of tissue damage in which cells are temporarily unable to function but may remain viable. So you realize that when there is blockage, we are saying that there is a secondary area of tissue damage in which cells are temporarily unable to function, but still they remain viable. So we are saying ischemia will cause the following. Okay. Okay, when there is ischemia, then there will be one impaired movement of calcium and potassium. So potassium and calcium will not be able to move as it's supposed to move. Then also we have high level of calcium. High levels of calcium are believed to trigger
I'm
the
able to
activation
get you,
of
but there is
enzymes
noise.
that attack neuron
Others
cell
are making
membrane.
noise.
Okay. So now, so now, the accumulation of oxygen free radicals which further disrupt the calcium metabolism. So we are saying that because of ischemia, there will be one impaired the movement of calcium and potassium, and also there will be higher levels of calcium, which is believed to trigger the activation of enzymes that attack neural cells membrane. And because of this, we are saying that there will be an accumulation of oxygen-free radicals which further disrupt calcium metabolism. And the presence of glucose is low. Now, when we look at the low presence of glucose, we are saying that perfusion area enhances lactate production, which worsens cellular damage and acidosis. So the presence of glucose is low, then perfusion area enhances lactate production, which worsens cellular damage and acidosis. An influx of fluid activated white cells and coagulation factors further clog the microcirculation. Then stroke associated with the hemorrhage is primarily related to an abrupt rise in intracranial pressure and ischemia followed by cerebral edema. Okay, so with intracranial bleeding, blood is forced into the adjacent brain tissue where hematoma forms. Okay, when blood in intracranial cerebral bleeding, when there is bleeding in the intracranial spaces, then we are saying blood is forced into the adjacent blood tissues, and where in these tissues, then we are saying that the hematoma forms. This will result in compression of tissues and even result in brain tissue displacement and herniation. Okay, is it clear? So now we look at let's look at the manifestation. So specific symptoms will reflect the site and severity of ischemic damage. So one, we look at the effect, the motor effect. Okay, when the motor effect, we are saying hemiparalysis or hemiplegia of the side of the body opposite to the ischemia. So you realize that when the ischemia is in the left side of the brain, then the right side of the organ will be affected. Okay, that's the motor effect. Hemiparalysis or hemiplegia of the side of the body opposite to the side of ischemia. Initially, we are saying that spastic progressing to spastic, okay? So you find that there will be spasm of the tissue, okay, initially. Then, when you look at dysphagia, that's the swallowing, okay? Swallowing reflex may also be impaired, and also dysarthria, okay? Dysarthria. Then we look at the bowel and bladder. Then we have frequent or urgent and urinary continence. You have a frequency or urgency and urinary incontinence. We also have constipation and also bowel incontinence. Then for language, signs and symptoms, when language has been affected, we have aphasia, which is the difficulty or inability to express self verbally, or difficulty or inability to comprehend speeches. So you find that this individual will not be able to communicate properly, okay? So it's either this individual will be very slow in communicating, or will be even unable to communicate. Then alexia, that's inability to understand written words. When somebody has written something for the purpose of communication, then this person will be unable to understand that communication. That's alexia. Then agraphia, there will be agraphia, and when you look at agraphia, we are saying that inability to express self in writing. So the patient will not be able to write. That's agraphia. That's in the when language has been affected. Then sensory or perception. So signs and symptoms of sensory include diminished response to superficial sensation like touch, pain, pressure, heat, and cold. One will not feel heat, will not feel pain when the sensory perception is defect, okay? And also diminished proprioception, that's loss of awareness of where various body parts are in relation to each other and the environment. So there will be diminished in proprioception. Then cognitive, emotional, we are saying emotional ability and predictability. Okay. So emotional ability and predictability. Then we have memory loss, depression, short attention span, loss of reasoning, that is judgment and abstract thinking, okay? So in cognitive, those will be lost. Then we have, as the cerebral edema increases, there will be changes in mentation, including apathy, irritability, disorientation, memory loss, withdrawal, drowsiness, and stupor or coma. So you find that the patient will go into coma, okay? Then other clinical presentations, we are saying there will be numbness or loss of sensation, weakness or paralysis on part or one side of the body, then headache, neck stiffness and rigidity, vomiting, seizures, dizziness, or syncope. So those are clinical presentations of CVA. Then we go on to look at the medical management. So under medical management, first we'll look at the investigations that may be required to be done on this client. Okay, one, it's a CT scan, that's computed tomograph scan, to review site of infarction. When you look at this scan will tell you where the obstruction is, whether it's hematoma and also shift of brain structures. So when you look through the scan, it will review the site of infarction, hematoma, and shift of the brain structure. Then the other one we are looking at is MRI. That's magnetic resonance imaging to review site of infarction. So when you do MRI, which is magnetic resonance imaging, will also review the site of infarction. Then EEG, which is electronic cardiogram, we are saying shows abnormal nerve impulses transmission. Then lumbar puncture for CSF analysis. Here, it's not done routinely, especially if there is increased intracranial pressure. So lumbar puncture should not be done routinely when you suspect that there is an increase in the intracranial pressure. Then also we have cerebral angiography. In cerebral angiography, to pinpoint site of rupture or occlusion and identify collateral blood circulation. Okay. So cerebral angiography can be done. So now let's look at the medical treatment. Respiratory support, we are saying maintenance of airway and delivery of oxygen as needed. So we are saying that intermittent positive pressure breathing and chest physiotherapy are very important in the management of this client. Okay. Then also we look at the IV fluids to maintain fluid and electrolyte balance. Fluids may be limited while increased intracranial pressure is a risk. Okay, so we limit the amount of fluids given to this client. Then also positioning. Positioning, we are saying that bed rest during acute stage. Okay, we look at bed rest in acute stage, and we are saying that activity level is increased as patient's condition improves. Then elevate head of bed at 30 degrees as prescribed. Hence, this client of ours, you need to elevate the head, head of the bed at 30 degrees. And also, this head of the bed may be kept up with the hemorrhagic stroke or patient with the increased intracranial pressure to decrease cerebral perfusion and improve venous outflow. Okay. So now, diet, we are saying this patient should be new per oral status and possible gastric tube if swallowing and the gag reflex are diminished, or if patient has decreased the log. Okay, so now when you look at the log, it means the low oxygen concentration. When the patient has decreased the low oxygen concentration, then we are saying we need to put up an NG tube in case this patient may regurgitate and swallow the secretions. So a low sodium and low fat diet may be prescribed to minimize other risk factors. So we need to look at the dietary part of this client. We are saying we need to give a low sodium diet. Why? Because we are saying that this may be hypertensive patient. Then also the fat, we are saying that you may have fat deposits within the arteries that may be moving, and they may cause the obstruction. Okay. So pharmacotherapy, we are saying we need to give anticoagulants. Anticoagulants may be considered in patients with severe or transient ischemic attack. Heparin, sodium, and warfarin. Heparin and warfarin, these are drugs, okay? These are anticoagulant drugs which can be administered to prevent the coagulation of blood, okay? Or liquefy the thrombus which may be moving in the system. Then antihypertensive agents such as the nifedipine to control blood pressure, which may cause cerebral edema or increase the intracranial pressure. So you need to give nifedipine depending on the severity. The dosage may range from 5 milligrams to 20 milligrams. Okay. Then ensure as you are giving these drugs, you monitor for side effects. Okay. So antiplatelet medications may also be given. And when you look at these medications, we are talking of aspirin in conjunction with the dipyridamole or sulfapyrazone. This to prevent platelet aggregation that may lead to thrombus formation. Then we have glucocorticosteroids, we have dexamethasone, and also osmotic diuretics, we have mannitol. These are administered to prevent or reduce cerebral edema. Okay. Then we have antacids and histamine. We have H2 receptor blockers, e.g. ranitidine, or to reduce the risk of GI hemorrhage from gastric ulcers caused by stress. Then we have antiepileptic. Antiepileptic drugs can also be given, which is phenytoin or phenobarbital, to control and prevent seizures. Then we have sedatives or tranquilizers to promote rest. These are used cautiously to avoid further impairment of neurologic function. Then we have analgesics. Analgesics, we have acetaminophen to control headache. Then we have two softeners, two softeners can be given. Then we have examples of two softeners. We have glucosate or bisacodyl to prevent straining, which can result in increased intracranial pressure. Then we have hemodilutions, e.g. albumin, crystallite fluids. These can be given as hydration to hydrate the patient. That's to promote hydration is promoted via fluids and volume expanders to decrease blood viscosity in order to improve cerebral blood flow. Okay. Then we look at the nursing care. We look at the nursing care first. We need to look at the aim of our nursing care. The aim is to, one, to prevent complications associated with the CVA. Then we also want to maintain a patent airway. We look at the patent airway to provide a nutritious diet to bring back the patient to his or her normal or near normal functional status, and also the nursing care of a patient with a stroke calls for total nursing care, in which all activities of daily living are done on behalf of the patient. We not say that this client is unable to perform activities of daily living, and so these activities of daily living are dependent on the person taking care of this patient, and in this case, the nurse who is taking care of the patient. So let's look at the position or environment.
Nomsa, they are getting your noise. They're telling me your sisters are making noise.
Okay, we look at
Keep quiet.
the environment where this client should be placed, and also the position. How do we position this client? Okay. Okay. Are you able to get me?
Yes, sir.
Okay.
Yes, sir, we're
So
getting.
let's look at the environment and position. So the patient is best nursed in the intensive care unit, where he or she will be closely monitored during the acute and or critical stage. So this patient is strictly under observation and hence should be nursed in the intensive care unit or near the sister's bed, okay, where the nurse, near the nurse's bed, where they can monitor this client easily. Then the patient is placed on bed rest with the head of the bed elevated at 30 degrees and positioned well to prevent the tongue from falling back. As we know that this patient may lose consciousness, then the tongue may fall back, resulting into occlusion of the airway. And so to prevent this, you elevate the head of the bed, okay? So also supplemental oxygen therapy can be given. Hence, you need to you may need to administer oxygen at preferably 100% oxygen from the cylinder or concentrator. Okay, so we are saying that the environment is kept as quiet as as quiet and restful as possible, and all activities that are known to increase intracranial pressure, such as coughing, straining, laying prone, muscle contraction, emotional upset, and abrupt head or neck flexion are avoided or minimized. You need to minimize all activities or all positions that may cause the patient to strain, okay? Then the patient is assisted to change position every 2 hours, okay? Or you may need to change the position of this patient every 2 hours and encourage to move independently. That is, if this patient can move independently, so that you prevent bed sores, okay? So you need to change the position of this patient 2 hourly. Then the affected arm is positioned with the hand elevated above the wrist and the wrist above the elbow to support venous return and minimize edema. Then shoulders are placed in neutral position with support as needed. Pillows, rolled towels, and sandbags are used to support normal body alignment with particular attention to prevent the external rotation of the hip. Okay. Then special care to avoid excess pressure or pull on the shoulder joint, which is extremely vulnerable to joint subluxation and adduction. Contractures should be put in place. Heels should be elevated off the mattress to avoid pressure injury, and the foot positioning to prevent foot drop. Okay, as we know, these may be complications that may arise due to prolonged bed rest. So also hands are split firmly. Supine position is avoided to prevent aspiration, as we know that this patient may be unconscious. So you need to ensure that the aspiration should be avoided. A side lying position with the head of the bed elevated 10 to 20 degrees should be maintained. Pressure area care and prevention of sore formation with the use of bib, elbow, and heel protection should be done. So meaning we need to look at all those areas that are prone to pressure sores. And these areas like the hip, the heel, the elbows should be protected to prevent the pressure sore formation. Okay. Observation. Under observation, immediately after the patient's admission, we focus on the focus of nursing care is on monitoring the patient's neurological status and also preventing complication while assessing the severity of this stroke. So we need to look at the neurological response, okay, of this patient. Hence, we need to strictly look at the Glasgow-Coma scale. You look at the vital signs also, and neurological checks are performed regularly to rule out the presence of intracranial pressure, increased intracranial pressure. So we need to use the Glasgow Coma scale is used to assess the level of consciousness and neurological response. Okay. Then assess for signs of pressure. Pressure, shearing or friction, damage during each position changes. So change the patient's position every 2 hours and record on the chart. Ensure strict input and output. So you observe for intake, whatever you are giving the client, okay, the patient, the fluids you are giving, and in so doing, you need also to take note of the output. Hence, record whatever the patient voiding. Okay. Then ensure strict input and output recording. Then patient will have an indwelling urethral catheter, therefore assess for any presence of infection. You assess the urine for infection. You assess the catheter, the size of the catheter for infection. So all those need to be considered. Then get urine samples for examination. You need to collect samples for examination. Nutrition and fluids. When you look at the nutrition and fluid status of the patient, this is depending on the condition of the patient. Feeding may be through the NG tube, okay? You can feed the patient through the NG tube, the nasogastric tube. Then assess the swallowing reflex of the patient. Ensure that the tube is in the right place to prevent choking and choking the patient. A highly nutritious diet should be given through an NGT such as milk, soup, custard, and ripe porridge. So you need to ensure that you feed this client, this patient. Ensure that feeds are at an acceptable temperature to prevent burning the gut of the patient. Then also fluids are strictly given. So I'm saying fluids are strictly given to prevent cerebral edema. Okay. Then we go to elimination. Ensure that the patient is not constipated. 2 softeners should be given to the patient to prevent straining on defecation. Then patient may have uncontrolled bowel movement. Ensure that a barrier cream is applied to the buttocks to prevent skin excoriation. Okay. Then hygiene. Since the patient depends on totally on the nurse, all hygienic needs should be done for her. I.e., when the patient needs a bedpan, you should be able, a nurse should be able to give a bedpan. Then pressure area care should be done as this patient may be unconscious and is prone to pressure sore formation. Oral care should be done, and also catheter toilet should be done to prevent infection. Ensure that the patient is in a dry, clean environment. Okay, so on the bed, you need to remove all bed cleansers. The debris should be removed to prevent pressure sore formation. Okay, then we look at the exercise and rehabilitation. So now we look at exercise and rehabilitation. So the rehabilitation plan incorporates active physical therapy, but the nurse needs to incorporate a variety of interventions into the patient's daily care routine. So positioning is fundamental to preventing complications such as contracture and the breakdown and skin breakdown. Okay, we know to say that this patient is immobile. Hence, we know to say that this client is prone to pressure sore formation and also contractures. So to prevent this, a nurse should always consider turning this patient, should always consider doing pressure area care to prevent these pressure sores and contractures. Exercises are important in the prevention of contractures. Okay, then coughing and deep breathing exercise and frequent positioning change. Sorry. Okay, are you able to hear?
Yes, sir.
Hello?
Yes,
Yes,
sir.
sir, we're able to get you.
Okay.
Ah, pity. The lesson is interesting.
Hey, sure. Doma.
Okay, so now we are saying coughing and deep breathing exercises. As you know that this client is bedridden, okay, is unconscious, then you expect the as a nurse, you need to anticipate the complications, which may be pulmonary edema. And when you look at this, we are saying that the lungs may be congested. By helping this patient to do deep breathing exercises, okay, coughing exercises, you may reduce this pulmonary edema. Also, positioning may help prevent this edema, pulmonary edema. So we are saying coughing and deep breathing exercises and frequent position changes prevent pulling of mucus and encourage ventilation of all areas of the lung. Okay. Are you able to hear?
Yes, sir. We're able to get you.
Okay. So
Yes.
now, is there any question?
Sir, actually, I raised my hand, but I don't know, you didn't give me the response. I was behind on predisposing factors and contraceptive pills. Contraceptive, yes. So I don't know, maybe if you can shed more
Okay,
on that.
on contraceptives, we are saying that when you look at the contraceptive, the tendency of those are hormones, okay? Those are hormonal drugs, and the tendency you find that there will be weight gain, okay? Meaning there will be accumulation of fats in the body, and these fats may dislodge and lodge somewhere in the arteries. And we said that this is common when this person who takes contraceptives also is a smoker. Is it clear?
Very much clear, sir. Thank
Have I
you
made myself
so much.
clear?
Yes, it's clear.
Okay, so Any other question? Any other question?
No question, sir.
We continue? Okay, let's continue. So now, still under we are still under exercises. We are saying that encourage patients with hemiplegia to exercise while they are still in bed. Not only prepares them for later activities, but also offers hope and a sense of optimism about recovery. So you know to say that this patient who is paralyzed, okay, hemiplegic, who may lose hope, and so you try to restore the hope of recovery, okay? You need to encourage this client to continue exercising, okay? Then perform passive range of motion exercises 4 times daily after the first 24 hours following a stroke. So in the first 24 hours, you know to say that this is an acute stage, but after 24 hours, you encourage passive range of exercises. Then, so frequent range of motion prevents joint immobility, tendon contractures, and muscle atrophy and weaknesses. So when you frequent do passive exercises or encourage the client to do active exercises, we are saying that this may help to prevent muscle atrophy and contractures. They also stimulate circulation and help re-establishment of neuromuscular pathways. It helps patients out of bed as soon as it is medically permitted. And also, exercises involves physiotherapies. You need to involve physiotherapists to assist with exercises. Then help patients use walker with guidance or use of crutches. So you need all those to be done. Okay. Then assist patient to be on a wheelchair or use a wheelchair. Then speech therapists should be consulted to retain the patient on speech has been, if it has been, okay. So depending on the affected part, you need to involve different cadres to help you restore the health of this patient, okay? Then the client may be taught to use the other hand, which is not affected. That is, in case of the right hand being affected, you encourage the client to use the left hand, which is not affected. So you need to educate the client, the patient, okay? Then health education. Let's look at the health education. If the patient is to be discharged home, the family needs clear understanding of the residual deficits. So the family needs to be aware of the inability of the patient, those that the patient cannot do. So the family and the patient need to have realistic, the patient and the family needs to have realistic expectations about the patient's abilities. So The family needs to know what the patient is able to do, and also the patient, him or herself, needs to understand himself on how far he should go in his care, in his or her care. Okay. Any question?
Good morning.
Any question so far? So also emphasis on the need of physiotherapy if there is residual disability as rehabilitative measures. The patient needs to understand that. Normally with severe, patients are allowed to go home when they are still, they are unable to move their limbs. So you need to encourage the family, educate the family on the importance of physiotherapy, and also, if possible, you need to involve those physiotherapists to rehabilitate the patients. The physiotherapist can arrange with the patient the days for seeing the patient. Okay, patients should avoid the high cholesterol diet and high sodium intake. We not say that these patients are on dietary restrictions, especially salt. They need not to take a lot of salt. Hence, you need to advise the clients on the salt intake and also on fat intake, as this may worsen their condition. Okay. So also, patient has to reduce weight if he's obese. Then reduce or stop smoking or alcohol beverages if that is the patient is taking alcohol. Reduce on that or stop taking that stuff. Then patient has to avoid prolonged bed rest and stress lifestyle. So you find that this patient may have a habit of stressful events. Okay, so you need to educate this patient on the reduction of prolonged bed rest or stressful lifestyle. Let's look at complications. So complications, we are saying contractures or disabilities. Normally, these contractures may come as a result of prolonged bed rest. And also, depending on the site of infection, then you find that the patient will have paralysis of the limb, of limb, face, facial paralysis. Then pressure sores may come about due to prolonged bed rest. Okay, bedridden. This patient is bedridden, then will develop pressure sores. Then pneumonia. Pneumonia comes about because of aspiration. Patient would want to vomit, but because of the paralysis of the GIT, then or the respiratory system, then the patient may aspirate, and this will cause pneumonia. And not only that, also because this patient is immobile, may result into hypostatic pneumonia. Okay, hypostatic pneumonia,
Yes.
which may come in. Then speech defect due to the size of damage. Then you find that this patient will have incoherent speech, or may have difficulties in writing or perceiving language, which is agraphia. Then alter the gait. Normally, you realize that these clients may have altered or disturbed position. Okay, is there any question? Any question so far before we conclude? Any question?
Listing.
And so, yes. Questions?
No questions, sir. There
Okay.
is.
So we've looked at severe, we've defined severe as a sudden loss, or which is acute loss of oxygen supply to the major organ, which is the brain. And also we looked at the causative. Under the causative, we looked at the three, which is the thrombus moving, the embolism, and also hemorrhage. Then we went on to look at the signs and symptoms. So with this, you note that you may identify the severe early, and it's better when it is noticed earlier. Then the treatment is treatment outcome is better than when it is identified later. So that marks the end of our discussion this afternoon. Okay.
Yeah.
Thank you for your participation.